for mesothelioma, as everybody knows, it likes to track wherever any drains may be, wherever the surgeon may have cut through the skin. So this is one of our patients who, it's a pretty big procedure. They make a big incision, and we have to give specific detail to where those incisions were, where those drains were, and then put margin around that. So just in case there were any, our doctors like to say, fingers of the cancer left behind that might grow out from these areas. And because this is at the skin and we're aiming deeper in, we use what's called bolus. So this is like the same texture as skin, and so it can be applied to those areas where the incisions and where the drains are to try to fake the machine into believing that the skin starts further out so that the intensity of the radiation can be targeted to those skin and drain areas. So like on, again, this patient, wherever the margin was, wherever the drain was, they would then apply this bolus, and daily the patient would come, they'd apply it's again custom made to that shape, apply the bolus. So the cradle is saved day to day, the bolus is saved day to day, the patient comes, they set up, lie back in the cradle, the therapist goes outside the room and brings up their specific plan, and then the radiation is delivered. And this is again just sitting in that position with the cradle, arms are up here, diaphragm, and where we're aiming at. And then this is our last slide, is just, again, the take-home message is that we have to always be conscious of damage to other critical structures. And we use a dose volume histogram so that we know ahead of the game, we know every single day how much radiation our target is going to get, and more importantly, how much radiation those critical structures are going to get. So it's very important to us that the opposite lung get very tiny dose, that the target over here get 100%, that's the 100% of the total dose, that the red is the spinal cord, that the radiation may go through, that we're at an acceptable level, that is usually 4,500 or below, and everything is calculated. The magenta is the heart, and before we even start with a patient that undergoes radiation, the plan has to be approved by the physician, and then it's still presented to the whole team of radiation. And they all put their heads together and decide that this is the best way, to hit the disease. And I think that's all of my slides. Thank you. Any questions?
How would a patient feel after going through this process?
Generally, you have to take it all into context. If it's somebody who has not gone through chemotherapy or gone through the whole surgery where they cut through their chest, usually they're in pretty good shape, except that the breathing that's being caused, problem breathing is being caused by the disease that's there, that's what's impacting them. So as the radiation starts working, they may actually have some improvement in their symptoms because the tumor is dying and it allows the lung to expand. Now, somebody who may have gone through surgery, of course, they're still recovering from that procedure. They're recovering from chemotherapy and blood counts that might have dropped from that. So sometimes we even have to wait, 40 days, 45 days after a surgery for the patient to be recovered enough to do the simulation and get the plan going. During the radiation, the biggest problem that we encounter is with nausea, many times because the diaphragm has been removed or tacked down on that side. That may start like the first or second week. And then once the radiation starts to kick in, because we may have to hit some of the esophagus, irritation of the esophagus starts. So they may have some reflux, indigestion, hiccups, with the nausea. They may not want to eat as much at that point. We have all of our patients see our dietitians, and they're a very vital part of our group. You know, they all meet our dietitians within the first 2 weeks, because we know usually problems start the third week on. So they're given, again, a custom plan, kilocalories, how much nutrition they need, how to meet that nutrition, how to deal with nausea, vomiting, bowel problems because of the narcotics they may have to be taking because of pain. So everything is taken into account, you know, and our nutritionists, you know, they tell us really what to do, because they know so well, you know, how to treat these patients. They know when they're going to get in trouble, and we see all of our patients once a week, you know, to make sure that the treatment is going well, that their energy is good, that their lungs sound well, or that if they have only one lung, that lung is good, that the blood work is recovering from chemotherapy they may have gone through. That the skin, you know, is having is not blistering, is not peeling, and deal with any wound care issues. You know, so there are a lot of people involved in delivering that.
How much time should people allot to be here during the treatment?
That's a good question. When we see them, say they had their surgery, they go home, they recover for about 4 to 5, 6 weeks, they come back, we'll meet them. We can do a simulation session with that wing board and that cradle the day after, but then they usually return home, because again, it takes like a week, 7 to 10 days to get a plan ready, because there's so many factors involved. So most patients, you know, they'll go home for that 2 weeks to prepare to come back, and then when they come back, they stay from 5 weeks to 6 weeks.